I know folks are still shuffling in, but I want to stay to our time schedule. So I want to thank folks for coming in. For those, I think most people know who I am, but for those folks who don't, I'm Mark Gauss, Superintendent of Schools. I just want to start off by thanking a few folks. I want to certainly thank the teacher leaders, the teacher representatives, and the presidents who represent each association of the buildings for just being open to the concept of having this workshop with us. We met briefly with them and the board chairs from each of the communities, and so being sensitive to the fact that benefits touch on an area of collective bargaining. We know that. It'd be a misnomer to say that they don't. But that's not why we're here this evening. Both sides, when we discuss this, recognize that collective bargaining as an entity is a sacred entity, and that's not what we're here for this evening. We're here to educate ourselves as to some of the unique variables that are involved in health insurance. We all know that health insurance, not just MDI and the Ambridge Islands, it's a challenge of national proportions, and it's very difficult to navigate for anyone, whether you're a public entity, a private entity. So recognizing there are some unique approaches to considering how we navigate that, that's what this is about. This is about trying to provide some information. We know that there will be follow-up questions, some that there are probably answers to tonight, some that will probably require research and information back. And a little bit about that, I want everybody to know that if you're not comfortable asking a question or bringing a point forward in public and you want to email it, we can deal with it that way. This session is going to be taped and available to all of our employees, all of our elected officials, and the general public. So we'll have that. The PowerPoint presentation that will be coming forward will also be made available to anyone too. So if there is information you're looking for and you don't see it either on our website or need it, please contact me. Before we get started and I introduce our presenters for this evening, I just want to introduce our AOS Board Chair, Heather Jones. Heather just has a few words she'd like to share.
Hi everybody, thank you for being here. It's a nice representation of the board and some teachers, so thank you. I just wanted to say that I'm very excited to hear what Cross Insurance has to present to us tonight with respect to the gap insurance. I see this as an opportunity for us to explore an innovative and collaborative approach to health insurance, the premiums, the cost of health insurance, and considering ways to sustain the Anthem Blue Cross Blue Shield insurance plans we have. So that being said, what we're doing tonight is we're not looking at taking away the Anthem Blue Cross Blue Shield program. We're really talking about trying to find a way to navigate the rising health insurance premiums and balancing the need for health insurance for you, the teachers, and controlling the budget costs or increases. So tonight, please listen, ask questions, and do know that the AOS school boards are approaching this as a learning opportunity. And should the plan be feasible, we are considering covering this cost through the budget, so that's not something that would be coming out of teachers' pockets. Thank you.
Thank you, Heather. And just again, a point of emphasis, as Heather said, this is not about shading away from Anthem Blue Cross Blue Shield. That's not what this presentation is about, and I think that's important to know. So with that, from Cross Insurance Company, we have Alan Robbins, who's the Vice President at Cross, and Donna Power, and Donna and Alan are here to present and then take questions, and I don't know who's coming first, or both. Alan, why don't you stand, and Donna, over to you.
Thank you very much. It's good to meet everybody tonight. I thought maybe I'd just give you an idea of how we ended up here, because we're not usually in the public sector here, insurance, but we are in the private sector. About 5 years ago, I accepted a role on a school board and happened to be RSU 25, and with any new school board member, well, the first thing you do is think you can change the world, and there's all kinds of money floating around that can be redistributed, especially back to the taxpayer. But quickly I realized that there's very little money. In fact, usually it's on the budget in most of the items, and most of the budget is really wage and benefits, as we all know. So Jim Boothby, the superintendent there, knowing that I was in the insurance business, asked if I could help and be on the CBA negotiations at that time with the support staff. So I did. I went on the committee, on the negotiations, got to learn the people, and I realized how great it was to really work with you folks, because I'd never really worked in this segment, and I really got to enjoy working with everybody. And I realized their struggles as well to keep their wage and benefits. So everybody wanted a wage increase, and nobody wanted to see their benefits go down, which is a real dilemma because, you know, health insurance has been going up anywhere from, in real terms, 10 to 12% for inflation year after year after year. So when you see your rate renewals come in, it's not particularly Anthem just passing on rate increases. The medical inflation factor from one year to the next keeps moving up at that level. So it's, when you see a 6 or 8% rate increase, it's actually a good rate increase. And sometimes I think they actually, you know, supplement the rate increase on their end. So Anthem, I think, does do a very good job, and the MEA Trust does a good job. So what this is all about is a way to and this may be a Band-Aid, I will admit, in what we're showing you here, in that maybe this is good for 2 or 3 years. I'm not suggesting this is the cure to a healthcare problem. And what we're actually doing here is looking at moving your deductible up to the highest level, and then finding a way more affordably to fill that gap in with another product. Now, we do this on the private sector, and we have done it for years, because our deductibles are $3,000, $4,000, $5,000 or more. So, you know, the market has pressured us to come up with different solutions, and one of those solutions is called this medical gap plan. So on the school board, we ended up putting all the support staff in RSU 25, 60 individuals or so, employees, went to the $1,000 deductible, and then we implemented the gap insurance plan. I had gotten done a couple years after that with my term on the board, and then Jim called me back in a year or so, I think it was, and we worked on the teachers as well. So RSU 25, the entire school district, is a $1,000 deductible base benefit. Okay? And it's not to say you guys will go there, but that's kind of what happened there. And we've implemented this gap plan, and it's worked really well. In fact, the teachers wanted to discuss it there in the CBA, because the support staff had such good luck with it over the 3-year period. So we know it works. I also know it works because we've used it for years, and we have 800 employees, and we have it in our own firm. So what I'm showing you here is something I even personally use. All right. So again, the concept that Donna's going to go over with you is about the possibility of moving your deductible up, and then having a product that would pay for your health care, your deductibles, and your co-insurance in a more cost-effective manner. So Donna Powers will never come up and walk you through the PowerPoint. We'll take questions too after she gets done.
Thank you, Al. Good evening, everybody. Can everybody hear me okay? I didn't think I'd have a problem. I first want to just talk about healthcare costs going up. I know Mark mentioned it, and I wouldn't be very good if I didn't talk about at least one slide with healthcare. But it is a national problem. And these are the projected U.S. spend for 2016. And I actually had trouble thinking how many zeros would be trillions of dollars, but it's a lot of money. And it's $3.35 trillion that the United States spent in healthcare in 2016, projected. That's huge. And to break it down per person, it's roughly $10,345 per person. There's about 320 million people in the United States. Not that everybody uses $10,345, but it gives you an idea of how high the cost of healthcare is. And a fact that a lot of people don't know is about 5% of the population utilize half of the US spend. And we see that in the groups that we handle on the private sector, that usually 5, 6, 8% utilize 50 or 60% of the overall claims for any given company. But this just puts it into perspective when you look at it at a national level. It's pretty scary. thought that we use that much in healthcare. And I looked back to see what 2015 healthcare spend was. It was $3 trillion. So in 1 year, the projection was $350 billion that it went up, just in 1 year. So Al talked about the GAP plan. GAP plans have been around for a long time. We're going back 15, 20 years. They've improved over time. But basically, the GAP plan, you pair it with a medical plan, usually that has a higher deductible. You have to have a group health plan in order to have the GAP plan. What the GAP plan does is it helps reduce your out-of-pocket expenses. Al mentioned that Bucksport School put in the $1,000 deductible plan as the base plan. Typically, you would have at least $1,000 anyways to put in a GAP plan. But by putting in the GAP plan, it can be an effective solution for you to help your out-of-pocket costs, but to lower the overall cost of the medical plan. And what is good about the GAP plan, it does not compromise your benefits. And you'll see that because we put together some examples to show you how the GAP plan works. First of all, with the GAP plan, everybody's going to need to complete a claim form at the beginning of the plan year. It's just a simple form, you'll turn it in, they'll send it to us and we'll process that. Most providers will bill the GAP company directly. If they don't, you would have to submit an explanation of benefit and a copy of your bill. Keep in mind, again, if this is something that you decide to do, you would have our benefits department in Bangor that would be able to help you with that process if you needed it. So the example that we're going to show you is we're assuming that the GAP plan will pay out $1,500 if you have an inpatient hospital stay. And if you have an outpatient service, whether it's outpatient surgery, MRI, lab, you have a $1,040 benefit. Combined, the GAP plan would help reduce your out-of-pocket up to $2,540. Okay? I know you really can't see this really good, but it is in the PowerPoint presentation. We thought it would be important to show the side-by-side comparison of the choice plan because the majority of you are on the choice plan. So up at the top, we highlighted in blue the deductible. So in network, it's a $200, $400 if you cover your family member, and then the $1,000 deductible for the individual, $2,000 for the family. And this plan breaks it up, your out-of-pocket, into deductible and co-insurance. So your deductible and co-insurance on the $200 plan is $1,200 for the individual, $2,400 if you cover any family members. The $1,000 deductible, your total out-of-pocket for deductible and co-insurance expenses is $3,000 if you cover just yourself, and $6,000 if you cover any dependents. Your plan also has an out-of-pocket limit for co-payments. So on the $200 deductible plan, your out-of-pocket for co-pays is $5,950, and on the $1,000 deductible, it's $4,150. That's your co-pay out-of-pocket max. And you are right, it would take a long time to meet up to those maximums. But if you have a child or somebody on a lot of prescriptions, you could get close to reaching those out-of-pockets. I know when my son was a very bad asthmatic, I spent $1,500 in co-payments over the year for him, for his prescriptions. When you look at the annual out-of-pocket, when you include your deductible, your co-insurance, and your co-pays, the out-of-pocket is the same. It's $7,150 if you cover yourself. It's twice that if you cover family members. So out-of-pocket is the same on either plan. We highlighted in yellow office visit co-pays. Office visit co-pays are going to be covered almost the same on either plan. The $200 deductible, it has a lower co-pay by $5 for the primary care and by $5 for the specialist. So that's a little bit different, but still co-pays. And then highlighted down towards the bottom, that's the prescription co-pay. So no matter if you're on the $200 deductible plan or the $1,000 deductible plan, your co-pays for prescriptions will be exactly the same. And the reason I stress that is most people use a prescription, so no matter which plan you're on, it's going to be the same. And we highlighted the co-pays because typically people may have 1 or 2 office visits a year. So basically they're the same when it comes to office visits and prescriptions, and even emergency room. Emergency room has the same copay whether you're on the $200 deductible option or the $1,000. It's both $200. So this is an example of an outpatient lab. So somebody needed some blood work. Again, up at the top, we put what the deductible is, what your co-insurance, what the out-of-pocket is, because we just like to remind you what your overall out-of-pocket expenses are. We wanted to do that with these examples. So highlighted in the gold in the middle, this is some lab that had to be done, $300 bill. On the $200 deductible plan, labs go towards your deductible. So we subtract $200 because that's your responsibility in out-of-pocket costs. So 200 from 300, you have $100 left over. You have a 15% co-insurance. That's where we came up with the $15. So your out-of-pocket expense that you have to pay for that medical service is $215. On the example with the $1,000 deductible, you have a gap plan. Again, you have $1,500 for inpatient, and you have $1,040 for outpatient. Same scenario, $300 bill. Your responsibility is $300. You have the gap plan to help pay for that $300 expense because you have up to $1,040. Your out-of-pocket liability is 0 in this example. We have an MRI. And we have the same format, so in the gold in the middle, the MRI is $1,400. Again, you have to satisfy the $200, and then you have your 15% co-insurance. So the total out-of-pocket is $380. $1,400 MRI on the $1,000 deductible. You have your $1,000 deductible, and your co-insurance is $80. The gap is going to cover up to $1,040, so your out-of-pocket expense is going to be $40. An inpatient hospital stay. So, again, it's a $25,000 bill, no matter which plan you're on. You have your deductible responsibility and you have your co-insurance responsibility. So, the total out-of-pocket for the inpatient hospital stay for that $25,000 bill would be $1,200. On the $1,000 deductible, you have to meet the $1,000 deductible and then the $2,000 co-insurance. So your out-of-pocket responsibility is $3,000, but you have that gap plan will pick up the $1,500. And again, the provider, if they participate with this company, they'll bill on your behalf. So your out-of-pocket responsibility would be $1,500. So even when it's a large bill, the difference in your out-of-pocket is only $300. In this example, you pay more in out-of-pocket expenses. We wanted to show you one with inpatient and outpatient. The reason being is typically, if you have an inpatient hospital stay, you probably had some labs or an MRI before the hospital stay. So we wanted you to see how it works with a combination. So an MRI, $1,400, the hospital bill, $25,000. $1,200 is going to be your out-of-pocket responsibility because you have your $200 deductible and you have your $1,000 co-insurance. With the $1,000 deductible plan, you're going to have your $3,000 out-of-pocket, your $1,000 for your deductible, the $2,000 co-insurance, so $3,000. But in this example, you can have the gap plan pay $1,500 for your hospital stay and $1,040 towards the MRI. So your out-of-pocket cost is only $480 because the gap plan is there to complement the medical plan. The gap plan probably sounds too good to be true, but we did an actual comparison of AOS 91. We had census data, so we knew how everybody was enrolled. And then we did the enrollment with everybody enrolled in the $1,000 deductible. So the way people are currently enrolled right now is 6.260 million. If everybody went to the $1,000 deductible, it reduces that down to 5,650,000. That's a huge savings. So I already talked how the gap plan works, so I want to get into some financial information. So the annual premium saved is $610,000. That's how much you would save moving over to the $1,000 deductible. The gap plan highlighted in blue with everybody enrolled in the gap plan is $321,514. The employee premium savings is $129,339. Because the majority of you are on the choice plan and the $200 plan. So that's why there's quite a savings with the employee premium. And then the district overall would save $159. So when you add the gap plan premium, the employee premium saving in the school district, it adds up to that $610,000. That's how we came up, that's how the math works. We thought it would be pretty powerful to show you a 3-year projection. Al mentioned, this is typically a 3-4-year run, and it will help reduce costs or make them not go up as fast as they would have. So again, up at the top, we have this current year. We have that 6.2 million, the 5.6, the $610,000 savings, and then what it costs for the gap. And that $288,000 figure up there, that's the savings between the employee premium savings and the district savings. And we did an 8% increase per year. That's actually lower than trend in Maine, but we wanted to go with something that's pretty realistic that could happen. So we show in year 1, if the enrollment stays exactly the same right now, that 6.2 million would go up to 6.7 million. If you put the gap plan in, that premium would go up to 6.3. So you're saving money in year 1. You go to year 2, that premium's going up to 7.3 million if you keep the enrollment as it is today. And with the gap, with the $1,000 plan, it goes to 6.5 million. The same thing with year 3. That premium goes up to 7.8 million. Again, it started off at 6.2. And then if you go with the $1,000 deductible, it's 7.1 million. So the overall savings for a 3-year period is 2.1 million. It's right down there in the bottom, $2,138,816. That's the total savings over that 3-year period. And then the actual savings between the employees and the school district is the 1.1 million, because we subtracted the gap premium from that total. Because the gap premium over a 3-year period would be roughly $964,000. So that's how the math is added up. So there's a significant savings year after year that would be able to help fund the gap plan and lower your out-of-pocket premium contributions that you have to pay. Because that premium going from 6.2 million now to 7.8 million in the 4th year, that might not be sustainable to keep that type of plan in place. So we wanted to show you how the gap plan works and then how the financials look with the gap plan. So we are open for questions. That was a question.
Yeah, and again, folks, just because it's being taped, we'll make sure.
I don't need
we have a
my-
question. Mark, I know you can be heard.
Yes. On the last page, $321,514. That's the premium that's paid for the gap insurance, correct? And that's the premium that's paid by, well, theoretically by the school board. That doesn't, in your in your prognosis here, that doesn't seem to go up over 3 years.
Because it doesn't have increases. It has not had increases in the last 15 years.
But it could,
It could.
How is that possible?
because they make money with it.
I want to make sure they can hear the response.
Yep.
Telling me- They're telling me that the loss ratios have sustained the premium. See, if you look at the fact that most of the employees don't ever even hit $1,000 deductible, you can see that there probably isn't that many claims going in. But
Did
it
you
could
just
go
say
up.
most employees don't hit $1,000 deductible?
Yeah,
I mean, you saw that slide up there where 5% of the population utilized over half of the medical expenses. There used to be a statistic that maybe 20% used the $1,000 deductible. I'm not really sure what that updated statistic was, I couldn't find it.
Hi. My family's probably in that 5%. So when I look at the examples, it seems like the gap coverage is great if there's a big, a big expense, a big lab, something like that. But I'm afraid we nickel and dime the insurance company, that's why they don't like us. So for me to oh good, we've hit our $200 or $400 deductible, that is great. And then we're gonna just keep going. It seems like by going to the $1,000 deductible with my, 1 appointment, 2 appointment, 3 appointment, I'm gonna have to pay that $1,000.
It depends on the appointments. If they're office visits, you're gonna have the office visit copay no matter which plan you're on. If it's lab, you're going to have the outpatient deductible amount covered up to $1,040. If you have inpatient, that would be $1,500 worth of coverage. But typically, the prescriptions and the office visits are gonna be paid the same no matter which plan you're on. So it really depends on how you use those services for your family.
No, I don't need the
follow
microphone.
that?
Yeah.
So, in other words,
It seems like we pay
you
for
have
the
Dr.
though,
Copay.
and then the copay.
Yeah, well, you have Dr. Copays that are
Yeah.
consistent between the two options that you would have, right? The $200 or the $1,000 deductible. Where this comes into play is the lab and X-ray. So if someone's having a lot of lab and X-ray, they could use up their $1,040. That's probable, possible. But
Jeff-
remember that your copays for your doctors, you're paying those under either plan. You have that covered too.
Jeff, please use the mics, because we're taking.
Okay. So,
Correct me if I'm wrong, but the examples you all gave, particularly the last one that had an inpatient and an outpatient benefit, that showed a payment from the gap coverage of $2,540, which is the maximum amount that the gap plan will pay, period. So if I do that on January 1st, my gap insurance is no longer useful to me for the rest of that calendar year, is that correct?
That's right.
That is correct,
But you've also reached your out-of-pocket
correct.
for your health plan, right?
So the only thing that you would have left would be co-payments. You would not have any deductible or co-insurance expenses after you pay that $480 out of pocket.
In other words, to reach the maximum on the gap, you've actually reached the maximum out-of-pocket on your health plan. So now you're into 100% coverage on your health plan, except for accumulating your co-payments that continue, which would have happened anyhow.
So, the payments that you make, you're killing two birds with one stone. You're going up to the ceiling of your gap payment, and somehow that's applied to your Anthem deductible
Sure.
also?
Sure.
Huh.
Because you have to have the claim.
Anthem is all right with that?
Well, you're gonna have the claim anyhow. Anthem's
Yeah, but-
covering your health claims. So you got $1,000, let's say you move to the $1,000 deductible.
Right.
So you're accumulating health expenses on your way up, right? Those are applied to your healthcare deductible. So in some way, they come back to the gap insurance. Because the gap is a reimbursement plan.
I see, so you are paying them,
right.
Right.
and they're getting their money from somebody, and they don't
Right.
care. It just,
Well, the
As long as they
providers are getting paid.
Right.
You gotta pay the providers,
yeah.
right?
Is the logic such that,
Mark made the first question that the 321 fixed cost of gap isn't changing. it seems like the logic is that the insurance product is measurable, you know exactly what the ultimate risk is, because you have the 2450 is what you're covering. And is the logic make it so that it stays the same price over many years at 321?
That would be some of it, but what's really happening behind the scenes is it's profitable to the Gap company. In other words, they're not losing money. That means the amount of claims coming into them is not exceeding the premium they collect. And it's the fact that, I know it's hard, when someone has a lot of health conditions, they assume everybody else does, but there's a lot of people who don't have healthcare issues. Well, remember, those people aren't submitting anything to the Gap, or very little. So, you have different dynamics that take place. Now, could the Gap price go up? Yes. It just hasn't, we're just telling you the truth that it hasn't had an increase. But it certainly could have an increase. I don't think we'd see an increase follow like we do with health insurance though. We did go to the MEA Trust and present the same thing you're seeing here to them. So we've had a couple meetings with them. We wanted to get their feel and input, or at least let them know what we were presenting. And that's about the extent. There was really no comment back and forth. We just let them know that we're out there and doing this and didn't want it to be some secret.
Any local providers directly billing?
Yeah, Eastern Maine, I have it, we have it ourselves. We've had it for 2 or 3 years
Eastern
personally.
Maine, therefore the
Yeah.
Coastal Hospital. How about MDI Hospital?
I don't know that. I haven't personally had a claim with them, we could ask them. But, yeah, Eastern Maine, I've used it myself. There's a card, it's a plastic card. It says SIS as the administrator. And when you go see a provider, you present both cards. So you would present your Anthem, Blue Cross Blue Shield, and then you present the Gap card. So what really happens is, the mechanics behind it is, the provider sends the claim to Anthem. Anthem would process the claim, adjudicate the claim. The claim comes back to the provider and says, oh, you have a $500 deductible, or $200 deductible, or whatever the amount applied to the deductible was. And then they automatically then send that off to the Gap as a secondary payer of the claim. That's kind of how it works. But we're trying to be completely transparent here, and there could be providers somewhere that don't accept secondary payer status. Okay? On a personal level, I haven't seen one yet. There certainly could be.
So I've accumulated questions while you've been talking. So is there a way to find a list of providers? Is there eligibility screening, like if somebody in your family has a pre-existing condition? And what about medical supplies like an insulin pump?
The only way we would know on the medical side is MDI part of Eastern Maine now?
No.
They're not, I keep thinking they were. Maine Coast is. So we know Maine Coast is because Eastern Maine is. So we have to call the claims department or the billing department at the MDI and say, have you been presented the Gap plan? Is it in your system as a secondary payer? Yeah, anybody can do it, we could do it. And usually, if they haven't seen it before, they load it, because quite frankly, the providers are happy to get paid. Because there are people who don't pay them, right? They don't pay their out-of-pocket expenses when they get them. So they're not opposed to having a third party pay the claim. There's no pushback on that. Your second question had to do with, yep, eligible. There's no pre-existing conditions on the Gap plan. Okay, no pre-existing. Durable medical is covered under the Gap plan. That would be pumps, braces, splints. It's out of outpatient. Yep, outpatient coverage. Yep, the Gap can be bought in any dollar amounts. They go all the way up to $10,000. We use an example here because it matches well with what you have for coverage. But quite frankly, it could be the Gap plan could be $3,000 inpatient, $2,500 outpatient. We just know what you have for a health plan, and to us it's very rich, and we're trying to fill the holes, the gaps, and do it in a cost-effective manner. and leave some money on the table, because that's what this is all about. Not just for the school, because that wouldn't work, but for also the employees are paying part of this premium. I mean, you're paying for your dependents. If you have a family, it's very expensive.
Are mental health services considered?
They're not. Yep. She asked if mental health services were part of the outpatient. They are part of your doctor copay on your Anthem, but then it's, because it's usually a doctor copay, it's not covered under the gap. Doctors and prescriptions are not part of the gap coverage. You have that coverage under your Anthem.
And that would be $65 higher copay on the
If you went to the $1,000 deductible plan, yes.
85%.
Yes, your co-insurance sharing percentage changes, yes, that's right. Any other questions we can help you with?
Not sure if you can, but do you know how many, I'm supposed to use the mic.
Yeah. Okay.
I don't know how many people are covered under in our AOS currently, and how many people that $321,000 is estimated to cover. That would be helpful information.
Sound pretty useful here.
Thank you.
So the information that we provided to them, the census data, while respecting confidentiality, we can provide that same data to you folks as well. And how many are covered and stuff, and so on. Go ahead, Nancy, please.
It was the current enrollment that they used as far as calculating that gap plan policy amount. And I can't remember how many there are that are covered. I'd have to look it up.
I think about 320.
You did it.
I knew it was on. If you don't have a question now, but you have a follow-up question, or you're thinking about questions, or what Alan and Donna have offered to do too, I hope this, okay, I see a hand back there, we'll come to you in a second. You know, they've offered to come back, and we can do this in small format settings, individual, school settings, or follow-up workshops to provide additional information for both board members, teachers, and other staff too. So know that this isn't intended to be a one-shot deal. Amanda, you had a question?
I don't know a whole lot about.
Oh,
I don't know a whole lot about gap insurance, I will say that up front, but obviously you've come in to do this presentation and to show us how it can be favorable to us. So I know one of the questions that I'm going to probably hear is, what would someone say are the 1 or 2 reasons that they don't want gap insurance? Like what, does that make sense? Teachers are going to hear this and they're going to, I mean, if we give them your presentation, they're going to want to know, okay, but what is it that we should know that some people don't like about it?
I want to play devil's advocate.
Sure, that's fair. It's always fair, because, healthcare isn't equal for everybody, right?
And it's a hot topic.
Yeah, it is. So I think if someone were to have just outpatient coverage, right, and you move to the $1,000 deductible, and you burn up your $1,040, you could be on the negative end of all this, right? Because you're going to use your $1,040 up. You didn't have any inpatient care. So that could be a negative. We kind of tried to show this on a negative slide, because there's always pros and cons to everybody and whether you use healthcare. If someone, however, though, has both, ends up with a significant health problem and ends up in the hospital and outpatient, there's no argument that the gap is better, because it drastically lowers your health care coverage. And if you have small claims, it's better because under the $1,000, you're accumulating it in some way between inpatient and outpatient, because this is first dollar coverage. These are dollars you get first. In other words, there's no deductible first. and then you get covered, you have the gap plan dollars that protect you on the bottom. But there are scenarios, like I just said, with if you used 100% outpatient, where that you could use your 1,040 and then have the remainder, right, of the $3,000 deductible left. So that's probability.
Alan mentioned it, but one of the questions I had is follow-up to yours, is, okay, so why aren't more schools looking at this? Why aren't people doing this? If this is, as Donna said, too good to be true, why wouldn't you do it? So I asked Alan that question, I'll ask you again so you can give the response, but the other piece that he mentioned is if we have staff, teachers, support staff, administrators, the area district next to us, Bucksport, I'd encourage people, publicly, behind the scenes, kick the tires and talk to your colleagues and folks about how that is or isn't working for them as well.
Yes, it's a good question. I'll answer what I answered to him. To Mark, is that this is a tough industry to approach. No one's been here before. There's a reason for it. There's politics involved. It's a long process to go through to get, in our position, it's, to sell insurance. It's a tough industry to get to know the people. If I hadn't worked on the board and really got to understand the dynamics that you guys deal with every day, I don't know that I would do this today. I didn't before. I've been in business for 30 years. So I just got to know the people and got to know the problem and got to know what the budgetary issues are and the financial issues are, which brought me to where we are today. So I feel comfortable talking to you because what I'm showing you is real. In other words, I feel confident what I'm showing you and telling you is true. Showing you good and bad is never one answer. But it does create savings. It does create times where people will greatly benefit from this. And as I said, on an outpatient-only basis, you could be in a position where you actually paid more.
I just want to look back on this slide where you show us the total premium savings and remind everybody that there is a component to the employee savings. And if you take that 129,000 and divide it by the 320-ish employees that we have, depending on what type of plan you have, there's some significant savings per employee and their family.
Yeah, you're right. And most of it, is in the dependent side, because if you look at the percentage that's paid by the schools, right, towards the employees higher, and then the premiums lower, right? But when you now you start talking about a family of $26,000 or thereabouts, that's where the savings really starts to add up. Is when the employees ends up paying a lot more because they have dependents on the plan.
I wonder if I fall into that negative scenario. I'm not sure if I'm understanding the negative one.
He wants you to use them.
Oh.
Saying you might fall into the negative scenario?
Yeah, I'm just wondering if I do. So I have a family member who gets like an infusion once a month that's several $1,000s, which would be an outpatient procedure, but we're rarely hospitalized at this point in our lives. So is that what you're talking about?
Yeah. Because you're going to use your 1,040 in this case.
So what would that mean after that? Because I think it's around $3,000 a month, I think, that she has. So what does that mean?
You'd end up paying around $2,100 out of your pocket versus what you pay now, like $1,200.
And Kelly, I think that ultimately the percentage of the Anthem that we have would probably not be the same. So it would be even more.
Well, it caps off no matter what, eventually, right? The claims hit a certain level. So your co-insurance becomes somewhat irrelevant at a certain point. Because it's a percentage after you meet the deductible. The only way to really answer that is to look at what you're actually saving in premium as well. Because remember, you're not paying as much for it either. So we'd have to add the two numbers together. Donna might have did this. I think we did a little, didn't we do a little thing in the office? Yeah. So yeah, you're gonna have to look at what you're totally saving on your dependents cost and what your total risk is. But we could do that. kind of feed it back to Mark so he knows.
So you, of course, the scenario that you showed us, you ran these numbers based on your scenario, correct? I mean, it could very well be that, you know, you're talking about $1,000 deductible. I guess my question is, how much of a slide do you know that Anthem has in terms of where to stick that higher deductible and what the savings are? Or do they just sort of have a stepped program that say, oh, it's $1,000, it's $2,500, and those are the gradations that we go into, you know? I mean, have you generated these case scenarios?
On actual numbers.
Well, I can see that, but are they actual numbers in terms of Anthem's
Good point.
deductible
Good
thing?
point, yeah. So I think what you're trying to tell me is where did we get the numbers on the Anthem side? Well, Anthem, based upon which plan you enroll in, gives the district, the school, an actual cost for employee on the $200 choice plan. And then if someone goes to the 1,000, what the actual cost for that is. So the numbers are fixed. Now, Anthem every year, you know, can adjust those numbers. So, I mean, that could come into play, the spread between the two plans.
Right.
Yeah. Good questions, by the way.
You had this scenario based on like a $25,000 inpatient, and I know that only 5% of the population makes, you know, they were seeing how much it costs. But the reality is that things happen. Just for example, my mother is a really healthy person, got a tick bite. She just spent 20 days in the hospital. 20 days. So if she was one of these teachers who was just as likely could walk in their yard, what's it gonna do to them? I mean, that, you know, how much is it gonna increase, how is the gap gonna help one of them, one of our great teachers here? That's, you know, I just lived through that and I don't want this on anyone else. How is that gonna affect them and what would be the best way for them to go?
Well, you know, again, we get back to the question, we don't know what's gonna happen to anybody and how it's gonna happen. So if she just, in the scenario there, if all she ever had is an inpatient stay, she never saw a doctor, she never had blood tests, she never had anything before she went in the hospital, then you're right, you'd end up having $1,500 for gap coverage. It'd be $1,500 remaining that she'd have to spend, versus the $1,200 that she'd end up capping off now, right?
But then.
That's a person who had no outpatient services.
Right, but when she was inpatient,
Mhm.
this was, say, like, you know,
Mhm.
there was multiple things done.
Yeah.
Fix on these teachers, and one of the things that can happen with Lyme carditis,
Mhm.
it literally made her heart almost stop.
Mhm.
You know, temporary pacemaker,
Yeah.
it can happen to a 20-year-old. So if those come under a separate category, just trying to.
No,
think
the Lyme,
outside the box.
it's not the fact that it's Lyme or
No, I mean,
heart
I said
attack
that,
or.
you know, it's these
Yep.
things that had, you know, it's an actual device that had to be used.
Mhm.
You had to go and have, you know, a heart attack.
Sure.
So if this happened to any of these teachers, you know, are we talking about if the gap coverage is gonna help them in those kind of things, like, it's about procedures and it has
Yes.
MRIs.
Mhm.
I mean, you know, that's what I'm thinking about.
Mhm.
If we are talking a woman, it's not gonna really help her. So it's-
Well, because her situation is 100% outpatient. It is going to help her.
But not.
It may, well, we don't know. We have to figure out what the total premium savings is too, right?
But if they go inpatient, it's more of a.
It's just inpatient. But if you go into the hospital and they did anything to you, say it's an emergency room visit, that's an outpatient. So that comes under your outpatient clause. See, if it's between outpatient and inpatient, you always make up with the gap because you get both pools of money. You get both sums, right? So then you're dealing with a very small amount of money out of your pocket. What's the difference we said?
$300.
Yeah, $300, which is, versus you having to pay $1,200. So in that, you know, if you have inpatient and outpatient, you're always better with the gap because you get $2,040, $2,540, I think the number is total. Yeah. Right, off a $3,000 out of pocket max. So you make out really well there. See? Okay.
Does, am I right in thinking that the gap insurance does not affect anything on the Anthem side? They don't care whether we have it or not? Like, it's not gonna change what they pay for other things? That's just based on which plan we choose?
She's asking, I think what you're asking is the underlying coverage with Anthem Blue Cross changing. Do they pay for things differently between one of your choices with Anthem and the next? Other than your out-of-pocket differences, Anthem pays the same under their contract, under their policy. So, if you had a certain illness, they would pay it the same way. It doesn't matter to them which plan.
Yeah, they don't refuse things because they're gonna expect you to cover it.
Well, they don't even know about the gap, other than they know about it tonight, right? And we've made them aware of it, right? I mean, other companies use the gap, it's not just,
It doesn't reduce your
no coverage reduction. How are you?
I'm a retired teacher from MDI after 40 years. And so I'm here because I know that whatever the MDI teachers choose will affect any retiree in their health plan as well. So I want to know how this is going to affect me and other retirees.
I understand the retiree program. When you retire, you choose the plan you go on. There's so many months before, am I right? That you have to be on the plan. You choose that you can retire on. So obviously, if somebody wanted the richest plan the Anthem offered, and you go on into full retirement, not what they call a carve-out or a companion plan. Because at some point, when you turn 65, you can switch over to what they call a companion plan. Right? Is that what you're on now? Mm-hmm. So the companion plan really wouldn't affect you one way or the other, because it's a different plan. So when you hit 65, you're under a Medicare companion plan.
The other thing we need to do to make sure we fully vet your question, because I'm aware that we carry our retirees for the purposes of Anthem Blue Cross. What I want to be doubly sure on is that, I think your question is that, will this gap insurance impact you as a retiree or others? And I want to make sure we fully explore that, because we know that we carry our retirees through the MEA plan, so whatever rate would be through Anthem Blue Cross, that is impacted, but I want to make sure on the gap piece, we will research that and report that back. Oh, I'm sorry.
But the gap plan would, if someone chose, they're on the gap, and then they were to retire, because let's say they went to a $1,000 deductible, and they had the gap plan with them, they could take both. It doesn't stop when you retire, you could have it both. But at some point, a retiree hits age 65, and then their plan can change to a companion coverage. And the MBT trust person's here, I think, too, might be able to answer that better than I can answer that. Is that person here on how the companion coverage works? No?
Okay, so the person retires and they're not 65 yet. Who pays for the gap plan for them? Do they?
We haven't got there yet. Okay? So, but that's it, yeah, sure.
So your question too, as I said, too, shades into, I want to be really careful about, I want to make sure we get everybody's questions and we get answers on the table, but some questions that may shade into collective bargaining, we can't go there, number one, or won't go there. And number two, when we're talking about the numbers that Alan and Donna presented, correct me if I'm wrong, it was on the employees and the census and the database for people we presently employ. So retirees are not included in this census data, nor in these projections, correct?
Correct.
Okay.
And I know your state retirement picks up a certain percentage of the premium too. And, that the gap has no relationship with the retirement plan. So I don't know how that would play out, but that's a good question, we'd have to find out. Okay.
Yeah, I'm a little embarrassed. I just texted my husband. It's actually $9,000 a month for this infusion. She started a new one a couple months ago. I didn't know, so.
That would be like crazy. So what would be the impact
Yeah.
there?
Well, the impact is just like it is now. She hits her cap on her medical plan, right? She hits her out of pocket, but that depended on the medical plan. And the same thing would happen, you know, if you went to the $1,000 deductible.
Right, like this year we paid an $800 deductible on that and haven't paid anything since per year. So would it continue to just be that?
I suppose if you chose to stay on the richer plan. See, we haven't gone, other than telling you how the gap works, as Mark will tell you, what we're trying to tell you is how the gap works. But there may be a scenario where you choose as an individual whether you want to go on the gap or not go on the gap. So,
Now, I just want to be conscious of the time because we're almost at 7, but there's some great questions and I don't want to cut anybody off. So Heather, if we're okay, can we go another 10 minutes? Okay, thanks.
do you have a question?
So I just wanted to clarify the goal. So the GAP plan would be paid by the employee as well as the Anthem plan, or the GAP plan is going to be paid by the district? And then secondly, the goal though is that to do that, I'm thinking they want everyone on this $1,000 deductible plan to save the money. Is that the goal?
I don't know what the goal is. Yeah, because it's really subject to your CBA negotiations. We're trying to bring a point that there's another option. So I don't know where this will head. It could be a voluntary benefit that you choose to save money because those people don't use it much. I don't know where this is going to head up. I think the issue here is we're trying to show you there's options. This is an option. Yep.
I just wanted to ask you something clarifying what Jan said. If you hit 65, you get the Medicare companion to go with your insurance. So you can't get gap insurance.
If you have GAP, you cannot. If you have the Medicare companion plan.
You can't get another gap.
Right, sure.
Because Medicare is sort of a gap.
Yeah.
But if you retire before you're eligible for that, we don't know what happens yet.
Well, I know what happened. You can choose your health plan. You have 4 different options, just like you do now.
But if you're a retired teacher and you haven't hit 65,
You could, let's say the gap was in
but they
place.
would pay for the gap on their own.
They would pay for the gap on their own, but maybe you want to. Because you're gonna have all that out-of-pocket exposure. And you're gonna have to weigh between you buying the low deductible health plan when you're retired and the cost of what that really is. Because you're gonna pay 60% of that.
I'm just trying to figure out for them. So
you'd have to weigh that, right? That financial picture?
but what they would have, but what any retiree has to take is if in negotiations it went towards this gap thing and everyone had to have the standard 1,000, all retirees would have to take that standard 1,000 as well. And they would.
I don't, but again, I don't know if Mark's there. I mean,
No, I know,
Yeah.
it's a scenario, I'm just trying to.
yeah, I don't think, none of that's been discussed.
I know it hasn't, I'm on negotiations.
Yeah.
But I'm just trying to think of those kinds of questions
Yeah.
that we need to have for negotiations and know that we're also trying to represent those retired teachers.
Yeah. Wear everybody out.
So there are definitely some follow-up questions. There are definitely some potential opportunities to come to do this at local levels with schools or staff who might have further questions. And there's certainly an opportunity, certainly I want to be careful on the collective bargaining process if either side wanted to do follow-up work or presentations that could be discussed. But a wealth of information, I'm really impressed by the questions that have come forward, so we have some homework to do. I certainly want to thank the teachers and the staff that considered having this workshop or attending this. This is a great turnout. I want to thank the board and the elected officials also for being open to the dialogue. And members of the public and retirees that have come out. That's great. I'm sure you're going to get a ton of questions or people, things that didn't come up here or that we didn't think of. And please email them to me and Nancy.
And it's also helpful too, if you want to really make sure they see it, Selena as well. So we would welcome any input, feedback, or questions you have. And then we want to make sure that we can get that information out to everyone. So Alan, is there anything you or Donna? And I certainly want to thank you guys for coming and presenting this. Thank you so much. So the PowerPoint, again, I will get that emailed out tomorrow. And then depending upon what, thank you, Jeff, for the taping, and we'll see how we upload that, and we'll go from there. So thank you very much, everybody. It's a great turnout. The AOS meeting will start in about 5 minutes in the library.